Natalizumab is a monoclonal antibody. It's directed against the alpha-4 beta-1 integrin, which is critical for lymphocyte adhesion to the endothelial wall. So it really is a very effective blockade at the blood-brain barrier. One thing that's really nice about natalizumab is that it is a targeted therapy. It doesn't provide broad immunosuppression as we think that some of our therapies may do. Natalizumab is an excellent and highly effective therapy for individuals with active relapsing MS. It has among the highest numbers for reduction in relapse rate and reduction in enhancing lesions of the therapies that we have approved.
It's a matter of opinion as to who should use Tysabri. On the one hand, some people feel that this should really only be used as sort of a rescue therapy for those who have failed so-called first-line or traditional first-line therapies, whereas others feel that because it's considered to be a more highly efficacious medication, that it should be really used as a first-line agent. I would find myself more in the latter camp. For those individuals, especially who have early signs of aggressive disease, I think waiting around to try to determine if they may have more disease activity before you use a more efficacious therapy does not make sense. It makes sense to try and use the most efficacious therapy as early as possible. And most people do consider, among the FDA-approved therapies available today in 2014, that Tysabri is most likely the most efficacious medication.
As with any potent therapy, and particularly immunotherapies, there's always some price to be paid in terms of safety. And the big risk that we have is progressive multifocal leukoencephalopathy known as PML. And as you'll recall, this is caused by the JC virus, which is generally a commensal virus in perhaps up to 50 to 60% of the adult population.
There are three main risk factors for patients who can develop progressive multifocal leukoencephalopathy. One is that the patient has to have been exposed to the JC virus, and we can test for that. Not only can we test whether or not it's somebody's positive or negative, we can test this even further and identify the index, and that can help us further stratify the patients who are high risk versus patients who are low risk. The next thing that we worry about is the duration of therapy on natalizumab, meaning that patients who have been exposed to the drug for longer than 2 years, are at higher risk for developing progressive multifocal leukoencephalopathy. The third thing is somebody who's been exposed to immunosuppressive drugs such as Novantrone or Cellcept, their risk also goes up significantly.
My personal belief is that natalizumab, Tysabri, should be used preferentially in patients with multiple sclerosis because it is highly efficacious, but that obviously you have to do that in the context of risk that's associated with that, and especially probably limiting its use or not using it at all in patients who have evidence of JC virus prior infection. I would note that there are some who also do believe, however, that you can even further mitigate that risk by perhaps using the medication not every 4 weeks, but perhaps every 8 weeks, although this is something that remains to be proven.